Yes, ma'am. Yes, proceed.
A 55-year-old male, Mr. Salim, coming from Virugambakam, shopkeeper by occupation, belonging to lower middle class, presented with chief complaints of swelling below and behind the right ear for the past 2 years. He was apparently normal 2 years back, after which he developed a swelling below and behind the right ear for a duration of 2 years, which was insidious in onset. Initially, it was smaller in size and gradually increased to attain the current size. It is not associated with pain. There was no history of sudden increase in the size of the swelling, or there was any relationship with the eating or chewing.
Okay, ma'am. What you want to among these 4 lines? What do you want to tell? So duration 2 years, insidious onset.
Uh,
Uh, yes. So initially small in size.
uh,
So
so
this
it is
point.
a slowly progressing swelling, sir,
Okay.
and it is not associated with pain. So there is no uh, uh, abscess or it rules out any abscess, and increase in the size of the swelling. If there is a sudden increase, it may be because of a malignant change. And with respect to chewing, I'm ruling out silolithiasis, sir.
Yes. So, Amma, duration of 2 years. Okay.
Yes, sir.
So insidious in onset and gradually increase in size. It means it is a benign swelling. Okay.
Yes, sir.
So in the parotid, 80% of the swelling you will get benign swelling.
Benign swelling.
Okay, only 20% only you will have malignant. Okay.
Okay, sir.
Okay. Okay. Yes.
There is no
Proceed.
history of difficulty in opening the mouth, no history of difficulty in swallowing, no history of
So what
frequent.
called the difficulty in opening in mouth?
Sir, if there is involvement of the pterygoid muscles or the jaw, temporomandibular joint, there will be difficulty in opening the mouth.
Okay, what it is called? It's a medical term.
Trismus.
Okay, trismus. What is a trismus? Trismus means, do you have any measurement to or any grading you are having it?
I don't know, sir.
Grading of trismus. Do you know?
No, sir.
What is the normal opening of the mouth?
Normal.
Anybody in the group, you can tell. Normal opening of the mouth. So 3.5 centimeter. Okay, 3.5 centimeter of inter-incisor distance. Okay, upper incisor. Not opening of the mouth means not the distance of upper lip and lower lip. It's the distance
Okay.
between the inter-incisor distance. Okay, upper incisor and lower incisor. Okay, normally 3.5 centimeter. Okay, so 3.5 grade 1, 2.5 to 1.2, less than 1.5 grade 3, like that. Okay. So where all you will ask the history of trismus usually?
Um, any
Mainly in which? Mainly
any
you will
pathology
ask
that
oral cavity. Yes, oral cavity malignancy. Okay, oral cavity
oh,
malignancy. So normally what they will tell, no, not Malambati score. Malambati score is to assess the airway. Okay, airway. Don't confuse with that. Normally they will for Malambati score 3-finger breath, 2-finger breath, like that. So some books says 3-finger breath. Normally the normal opening mouth will allow finger. Okay, but you have to tell the measurements only. So 3.5 centimeter, more than 3.5 centimeter, or less than. You have to measure because the finger breath varied to the person to the person. Okay, examiners may be short and shouters. Their finger breath may be larger than the patient's mouth. Okay, you should tell the standard measurements in all cases, not only that trismus, in all things like how will you live for a subtotal thyroidectomy. You should not tell that thumb, tip of the thumb. You have to tell some measurement. Less than 8 gram, I will leave thyroid. Okay, like that you have to tell standard measurement. Okay.
Okay, sir.
Okay.
There was no history of difficulty in swallowing, no history of fever, no history of trauma, no history of ear discharge or pain, no history suggestive of facial nerve palsy like drooling of saliva or inability to close the eyes, no history of swelling elsewhere in the body. And
Why
no,
you asked no history of a fever?
sir, in case of abscess, parotid abscess, there can be fever.
Okay. More than abscess, what is the most common thing? Abscess. Did you see any abscess, parotid abscess?
No, sir.
No. Then you may get one common conditions, no?
Mumps like that.
Yes, very good. Mumps. Mumps is the most common condition which causes fever.
Yeah.
Okay. How will you come to diagnosis of mumps?
So there will be a prodrome illness, and there will be bilateral parotid swelling.
Okay,
Initially, they start with single.
You will ask the history of prodromal symptoms. Okay, agree.
Yes.
Okay,
Then bilateral involvement of parotid.
okay, very good. Accepted. Second, bilateral. Mostly the mumps will involve bilateral parotid. Okay, accepted. Then very important diagnostic histories. History of exposure to that patient. History of exposure to the mumps patient. Okay, you need not do any test. History of exposure 2 days back with the mumps patient means this patient is typically may get mumps infection. Okay. Okay.
No history of dry mouth and dry eyes. No history of loss of weight and appetite.
Okay. Why you are asking no history of dry mouth and?
So to rule out Jordan's.
Okay. Then what's here? Here what's the point in this parotid swelling?
Sir, it will cause involvement of the lacrimal gland and salivary gland can be there in.
Okay, that's Sjogren syndrome. Okay.
Yes, sir. Or otherwise, there can be sarcoidosis also. Like.
Okay. So here it may be a malignancy that lead to that atrophy of the glandular secretion that leads to the dry mouth. Okay.
Okay, sir.
Okay. So no history of swelling elsewhere in the body. You told in the history itself. Do you know why you want to give importance in the history itself?
Sir, if there is any kind of lymphoma, there can be other lymph node enlargement also. We cannot say only parotid.
Tell me.
Sir, if there is any enlargement in the lymph nodes, it could be a lymphoma.
Okay. Yes, very good. To rule out the lymphoma is our main thing. Okay. Okay. So first you have to history of swelling. First you go to the surrounding region. You got to tell why nearby region.
Rule out.
Rule out.
Spread, sir. During malignant changes, there can be involvement of the nearby structures.
Yes. To rule out that lymph nodal involvement. Okay. Okay. Yes, proceed.
The past history, no history of similar complaints in the past, no history of tuberculosis, asthma, diabetes, hypertension, epilepsy, and jaundice, no history of chronic drug intake or drug allergy, no history of previous surgeries or hospitalization, no history of radiation exposure.
Okay.
Personal history, normal bowel and bladder habits, consumes mixed diet. He was a non-smoker and non-alcoholic. family history is not relevant.
Diet like that. Okay, you have to tell vegetarian and non-vegetarian diet, because mixed
Okay.
diet, mixing of carbohydrate, protein and fat. So the vegetarians also will consume mixed diet. Okay,
Okay, sir.
you have to tell vegetarian or non-vegetarian.
Okay,
Okay.
sir.
Okay, why you want to ask the history of the smoking, history of a non-smoker, what's the
Sir,
importance
it
to the?
can be associated with the Wharton's tumor.
Okay.
Smoking is with
Yes.
Wharton's mucoepidermoid carcinoma.
Some points about Warthin's tumor.
Sir, all tumors are mostly common in females, except this tumor, which is common in males. And
Very
and it is a lymphomatous tumor, sir. Actually, it is not. It's a. It's also called a cystadenomal lymphomatosum,
okay.
and it is thought to be because of the embryological origin. The jugular lymph sacs would be uh, got inside the parotid gland, so that will manifest later as Watkin's tumor. That's one of the theory, and it is rarely malignant. So it doesn't progress to malignancy so fast.
It usually occurs above 60 years. Okay, another point is it usually occurs above.
And it
And
involves the lower pole of the parotid.
very good. Another important point is it involves lower pole of the parotid. And one more important point.
Mm,
It is also involved bilaterally.
yes, sir.
Okay.
Often 10% cases pilot.
Yes, involves bilaterally. Yes, very good. Please proceed.
On general examination, the patient was conscious, oriented, moderately built and nourished. No pallor, icterus, cyanosis, clubbing, pedal edema, and generalized lymphadenopathy. His vitals were
Importance of
non.
lymphadenopathy. Why you specifically want to tell lymphadenopathy? Lymphoma is also one of the thing is commonly present in the parotid. Okay, so in the Bailey have one classification. Okay,
Yes,
did you read about it?
yes, sir. There was
Yes, adenoma, carcinoma, non-epithelial tumors,
like hemangiomas.
lymphomas, yes, lymphomas, and secondary tumors, unclassified tumors, and tumor-like lesions. Okay, this is the simplest classification given in the Bailey. Okay.
Okay, sir.
So so what's the most common lymphoma? Regarding the lymphoma, what's the commonly involved lymphoma?
Non-Hodgkin's.
Yes, very good. Non-Hodgkin's lymphoma is commonly involved. Okay, very good. Proceed.
The pulse was 80 beats per minute, regular in rhythm, normal in volume and character, no vessel wall thickening, no radio-radial or radiofemoral delay, felt equally in all peripheral pulses, vessels. Respiratory rate was 16 per minute, abdominothoracic type, blood pressure 110/70 millimeter of mercury, measured in the left upper arm in sitting posture, temperature afebrile. On local examination, after explaining the procedure and obtaining the consent, added.
And, what is the another importance? You tell the history of smoking about Warthin's tumor. Okay. What about that alcoholism?
Alcoholism is associated with sialadenosis. So that is one of the things seen in parotid.
Okay. Okay. What can you tell me some points about alcoholism and parotid?
So, alcoholics are more prone to dehydration.
Yes.
So they are prone to get parotitis.
Yes. Okay.
Mm.
So that is also involvement of
Bilateral parotids.
bilateral parotid. So that's why that Vijaykanth had that bilateral parotid involvement of because of chronic alcoholism. That may be one of the reason why he have that bulge in that nearby both ears. Okay.
Okay, sir.
Well, without FNSC we can't comment. Okay. Anyway, but alcoholism will cause bilateral parotid involvement.
Okay.
Okay, you told that mumps causes some prodromal symptoms. uh, in your relatives, who will you want to, the God will ask you, your relatives will get mumps. Who will you prefer? You will prefer children or you will prefer adult for mumps infection? God will say, anyway, I am going to give one person as mumps. To whom you want to give? You are a distant relative. You want to affected by a kid or adult?
Children, sir, because one time if they get, they'll get full immunity for the rest of the.
Yes. Okay. It's acceptable point, but our focus, my point is not that. That's a no. So it will gives lifelong immunity. The point is it gives lifelong immunity. If the child infected, the child will get lifelong immunity. Okay, I accepted. But what else? Do you have any other point?
No, sir.
Okay, if adult gets no, that will cause severe complications. But in most of the time, in the children's, they will have only mild form of infection only. Okay, but if the adult get, they will get severe complications. Okay, can you tell me what are the complications of mumps?
So it can involve the other exocrine glands like pancreas, gonads, oophoretus pancreatitis can be seen. So.
Yes, yes.
And in children, it can go for meningoencephalitis also.
Yes, yes. It causes oophoretis, it causes architis, it causes meningoencephalitis, it causes pancreatitis. Okay. So it also in the, if it comes to the adult means, that may cause infertility also. Okay. So that's why prefer to get children, but it will go only that it will give mild symptoms, cough, cold, so mild parotid enlargement, but it will set spontaneously, and also the children will get lifelong immunity. Okay.
Okay.
Okay, that's one type of parotitis caused by virus. Can you tell me some other organisms which causes parotitis?
Para-influenza viruses, echovirus.
Yes, so para-influenza viruses. Okay, echoviruses. Coxsackie A and B. Coxsackie A and B. So these are all other viruses. Can you tell me some bacteria which causes parotitis?
Staphylococcus and Streptococcus viridans.
Okay, Staphylococcus. Okay. Very good. Okay. Proceed.
On inspection, a single hemispherical swelling of size approximately 3 cross 3 centimeter below and behind the right ear with well-defined borders, and the extent was the upper border was 3 centimeter above the angle of mandible, lower border was just above the angle of mandible, anteriorly extends up to 1 centimeter in front of the angle of mandible and posteriorly up to the mastoid. The skin over the swelling was normal, no scars, no sinuses or dilated veins or visible pulsation. Lifting of ear lobule was present and the retromandibular groove was obliterated. On opening of the mouth, the swelling becomes less prominent. On clenching the teeth, the swelling becomes more prominent. And no other swellings elsewhere near the actual swelling.
Okay.
And on inspecting the oral cavity, the opening of the parotid duct appears normal.
Okay, where the parotid duct is opening?
Opposite to the crown of the second upper molar tooth, sir.
Okay, opposite to the crown of the upper second molar. Okay, very good. So all words you should tell: upper molar, opposite, and crown. Okay, so all the words you have to tell. Okay, proceed.
And tonsil is not pushed medially.
Okay.
On palpation,
So, why do you want to mention that tonsil is not pushed medially?
actually, the parotid has a superficial and a deep lobe. If the deep lobe is involved, then it can enlarge into the parapharyngeal space, pushing the tonsils medially.
Okay. How superficial and deep lobe? No. How much percentage of superficial lobe? How much percentage of deep lobe?
80% superficial, 20% is deep.
Okay, very good. 80% in the superficial, 20% is deep. Okay.
On palpation, the swelling was not warm or not tender, and inspected findings of size, shape, and extent were confirmed. Surface was smooth, skin was pinchable with firm consistency. Swelling is mobile in both horizontal and vertical direction, but not above the zygomatic arch. On clenching the teeth, mobility is not restricted.
Why you're told that Karthikeyan? What is Karthikeyan?
Sir, the parotid swellings are usually we cannot move the swelling above the zygomatic arch because of the investing layer of the deep cervical fascia will cover the parotid, and the upper margin will be attached to the zygomatic arch, to the inferior border of zygomatic arch.
Yes, okay, very good.
And on palpating the parotid duct was normal.
Okay, what's the length of parotid duct?
5 centimeters.
Okay, what's the name of parotid duct?
Stenson's duct.
Okay, Stenson's duct. What's the name of submandibular duct?
Wharton's duct.
What's the name of minor salivary gland? Sublingual duct.
Bartholin's duct.
Bartholin's duct. Okay, very good. So sublingual liquor will get in bar. Okay, so that's the mnemonic.
Okay.
Liquor, sublingual Bartholin's. Okay. Parotid Stenson's. Actually, I put mnemonic. Parotid in a P. Somasundaram. It's my father's name. PSS. Parotid is Stenson's duct. Okay.
Okay.
Length is 5 centimeter. Okay. What's the? Okay, proceed.
Bimanual palpation of the parotid gland. There was no deep flow.
Actually, the term is not bimanual, digital palpation.
Okay.
Okay, by digital palpation. So, no deep lobe enlargement. Okay, what are all the things you can see if deep lobe is involved? A clinical examination. What are the things you have to see?
If deep lobe is involved, there will be tonsil or fossa will be pushed medially. Uvula may also be pushed, and
Both anterior pillar and posterior pillar and soft palate, all are pushed medially. Okay.
Okay.
Okay. Proceed.
Examination of the left parotid region was normal. Examination of the submandibular gland was normal. Examination of the oral cavity, opening of the parotid duct was normal. Tonsil was not pushed medially. Uvula and midline, lips, palate, gums.
Okay, what are all the you have to see in the opening of the parotid duct? Okay, then what else you see?
So to look for any minor salivary gland involvement. So I'm looking for palate, gums, and.
Okay. Then what else? What is the importance to see the opening? Can you see with the naked eyes that parotid duct open?
Yes, so we can.
Actually, it's very difficult to see with the naked eyes. The opposite to the crown of the upper second molar. Huh?
Okay.
How can you find it out?
Sir, if we press the gland, saliva can come out.
The palpation, you have to press the gland and you got to look for any discharge. Pus, anything is present. Also, you got to see that also. Okay. Usually with the naked eyes, it's very difficult to find out that parotid duct opening. Okay.
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 And examination of the lymph nodes, no enlarged or palpable cervical lymph nodes.
Okay.
Examination of the facial nerve, facial symmetry was maintained, wrinkling of forehead is present. Patient is able to frown, close the eyelids against resistance, nasolabial folds were normal. Able to blow out the cheek, no deviation angle of mouth, corneal and conjunctival reflexes were normal.
Okay.
Shall I proceed, sir?
Okay, proceed.
Systemic examination.
No, anything abnormal you have to tell in any system?
So we have to look for respiratory system.
Okay. Respiratory system, you have any abnormality?
No, sir, no abnormalities in any systems.
Why you got to see specifically respiratory system?
Sir, as I said that infectious etiology, mostly it will be an upper respiratory tract infection.
Okay, proceed. Not relevant to the. Okay,
I'm summarizing. A 55-year-old male presented with painless swelling in the right parotid region for the past 2 years, gradually increasing in size with no other symptoms. On examination, it's not ovoid, it's actually hemispherical, sir, as an error. A hemispherical firm lobulated swelling of 3 cross 3 centimeter with a well-defined modus was seen with no signs of cervical lymphadenopathy and facial nerve involvement.
Okay. What's our professional diagnosis?
It's a right benign parotid tumor, most likely to be a pleomorphic adenoma, sir.
Okay, why you are saying this is a pleomorphic adenoma?
First, it's a slowly progressing tumor. It has taken 2 years of duration. Then,
and after 2 years also, it's not so much big size. Okay.
and small,
Okay.
and there's no lymph node or facial nerve involvement or any history or like a sudden increase in
Okay.
size, pain or swelling.
Okay.
These all points towards benign.
And also the surface is smooth, margins also well defined.
Well defined with lobulation.
Smooth surface, slow growing thing, no facial nerve involvement, no nodes is present. All favor for this is a benign condition. Okay.
Okay.
So in the parotid 80% you will get benign. So we are going with the benign condition. So pleomorphic adenoma is the most common benign condition. Okay, which one is the most common malignant parotid tumor? Can you tell?
Mucoepidermoid carcinoma, sir.
Yes. So most common malignancy is mucoepidermoid carcinoma. Okay, very good.
And my differential diagnosis would be Barton's tumor and parotid lymph node enlargement.
Okay.
So first, I would like to do some investigations, sir. Baseline investigation.
Okay, in the serology you have written what are the investigations? Why? Do you have any?
Sir, in HIV, there can be HIV parotitis, which will present with multiple cysts.
Okay. Okay. Can you tell me some points about the HIV induced parotitis?
Sir, it usually has, it will be similar to Sjogren's presentation, like dryness.
Yes. Histologically, both are look like same. Okay, very good.
And it will be mostly multiple cystic lesions with this. In MRI, we can see that multiple cysts with cystic appearance.
Okay. Okay, okay, ma'am.
Specific investigations, first I would do an ultrasound and then ultrasound guided FNAC.
Okay.
CCT neck and MRI neck.
Okay.
And management is right superficial parotidectomy, preserving the facial nerve.
Okay, why you want to do superficial parotidectomy?
As the histories and the examination suggested, there is no deep lobe enlargement and only the superficial lobe is involved. And the facial nerve is facial venous plane of patty is in between the superficial and the deep lobe. So to preserve the facial nerve, I'll remove only the superficial lobe.
Okay. Okay. Can you tell me what incision you use for superficial parotidectomy?
Lazy S incisions, otherwise called modified Blair's incision.
Okay. Bailey's modified Blair incision. Okay. Okay. Can you tell me the procedure how you will do?
Yes, sir. After preparing the patient, after putting the incision, lazy S incision, which is an auriculomandibular cervical incision, we have to lift the flap and then we should mobilize the superficial lobe of the gland, then identify the nerve, facial nerve using the pointers, and then we have to remove the tumor and then close it back again.
Okay. Can you tell me the location of parotid? Then only you can run the flap.
Yes, sir. The parotid zone, it is bound by 2 horizontal and 2 vertical lines. The horizontal lines pass through the superiorly along the zygomatic arch and inferiorly along the angle of mandible. Anteriorly along the vertical line passes through
the flap has to rise up to inferior belly of a digestic. Okay.
Okay, sir.
Okay. Anteriorly?
Anteriorly up to the mid line passing to the midpoint of the zygomatic arch, and posteriorly up to the mastoids.
Okay. Okay. Proceed. So you want to do any like a true cut biopsy?
No, sir. In biopsy is actually contraindicated in parotid tumors.
Okay, why? True cut biopsy, yes. Okay.
Because we may injure the facial nerve, or there can be seeding leading to recurrence can happen, sir. Especially in pleomorphic adenoma, there are some pseudopods, so that can give rise to recurrence.
Okay. That point is not related here, because why the parotid tumor is recurrence means because of pseudopod. Okay.
Okay.
This true cut biopsy will not disturb the pseudopods. That's not related. Okay. True cut biopsy, why avoided means the first point you have told, right, that it will lead to the seeding of the tumor to the skin. Okay.
Yes.
Okay, and that's the main point. Okay, when you will advise that true cut biopsy? Anyway, some conditions we will do true cut biopsy. If FNAC is not inconclusive, or that the tumor is more aggressive, or you are suspecting something else than the parotid, then you can take a true cut biopsy. Okay.
Okay, sir.
Okay. Okay. Proceed. So what are the complications you will get
of parotidectomy, sir?
After parotidectomy?
There can be bleeding, infections, or there can be flap necrosis. It can lead to fistula, or a temporary facial weakness, or a permanent facial weakness. And
okay.
if greater auricular nerve is usually sacrificed, it can lead to anesthesia in the earlobe.
Numbness. Okay.
And siloseals.
Okay. What about phrase syndrome?
Phrase syndrome. Yes.
It's a very important. No. So ultimately, that examiners will ask about what is phrase syndrome. See, if you are, they will ask the next question, what is phrase syndrome? So the examiner will ask. So I also ask, what is phrase syndrome?
It is the aberrant innervation. So the postganglionic nerve fibers of the auriculotemporal nerve will develop, will grow and innervate the sweat glands over the parotid region, sir.
Okay. Which is sympathetic, which is parasympathetic?
Sweat glands are parasympathetic. I mean, they are sympathetic, but they are cholinergic nerves. Yes.
Sweat glands is actually sympathetic.
Sympathetic, but cholinergic.
Parasympathetic is auriculotemporal.
Auriculotemporal.
So aberrant nerve development in the parasympathetic to the sweat glands. Okay. So the patient while sweating, while he or she see the food, automatically parasympathetic will stimulate, that leads to the sweat gland.
Sweating and redness of the.
Okay, sweating and redness. Okay. Okay, what's the test you will do for that?
It's minor starch test, sir. First, we have to dry the skin and then put iodine and dry it. And
first, you got iodine and allowed to dry. Okay, first point. Next.
Yes, sir. Then we have to put anhydrous starch without dried starch over the.
Then you got starch that also has to try. Okay. Then.
Yes, sir. Then when the patient eats or drinks.
Okay. Then you got to show the biryani. That's enough. Okay. Okay. If you show the biryani, then that
sweating will turn the.
Yeah. Okay. That starch will turn to blue color. Okay.
Okay, sir.
Okay. Okay. How will you prevent? Frey syndrome?
We can use extracapsular dissection instead of superficial parotidectomy, sir. There we will preserve the capsule, so there won't be any growth of the nerves. Then,
No, not this point is not for that. That extracapsular means what means? Extracapsular tumor, you are removing the extracapsular tumor means you can leave some parotid tissue also. Okay. To prevent the nerve damage only, you have to tell that word extracapsular excision. Okay. Rather than the superficial parotidectomy.
Okay, sir.
Okay. Okay.
And we can prevent by placing a sternocleidomastoid flap or a temporal aphasia,
okay,
or
very good.
any artificial membranes.
Yes, very good. You can insert some artificial membrane between the skin and the parotid bed.
Yes.
Okay. Okay. Anyway, the patient has developed a Frey syndrome. How will you manage? Because in the most of the time, you will get questions like a Frey syndrome. How will you manage the Frey syndrome? Okay.
Okay, sir.
If you are getting the parotid tumor, you will definitely have these questions. What is Frey syndrome? How will you treat the Frey syndrome? How will you avoid the Frey syndrome? Which is with sympathetic fiber, which is parasympathetic fiber? These questions routinely you will get. Okay. Okay.
We can give antiperspirants.
Okay, antiperspirants.
And we can do a tympanic neurectomy or Botox. Botulinum toxin can be used.
Yes, botulinum toxin. Very good, very good. Okay. Okay. So if you the FNAC has come like adenolymphoma. Okay, then what investigation you like to do?
Technetium scans.
Yes, very good, very good. 99
technetium
scan is the diagnostic of choice. Okay, for adenolymphoma. Okay. Okay. So it's a benign condition or malignant condition?
It is a benign condition, sir.
Okay, but anyway, we will give radiotherapy. Even though it's a benign condition, we will give radiotherapy.
Yes, sir.
Okay, why?
Because it's radio sensitive and.
No, not because of radio sensitive. We are giving radiotherapy. Because this is pseudopods, no? You told that point. Pseudopods. That leads to the recurrence. So it is it's most commonly it will recur parotid after superficial parotidectomy. Because of the leaving some pseudopods will definitely leads to recurrence. Okay. To prevent the recurrence only, we are giving radiotherapy. Okay, sir. Okay. But very rarely we will give radiotherapy for benign condition. If the examiners sometimes ask for which benign condition you will give radiotherapy, you tell pleomorphic adenoma. Okay. Okay, sir. Okay. Okay. So he's a male. He's a smoker. No, sir. Not smoker. Not an alcoholic. Okay. Okay. Do you have any mnemonic to say that what are all the complications of parotidectomy surgery? I had it as F's, some 5 F's. Yes, 5 F's. Okay, what are the 5 F's? Flap necrosis. Okay, very good. Fistula. Okay. Frey syndrome. Okay. And, facial weakness. Okay. Temporary fermentation. Okay. Okay. So, are you able to have stones in the parotid? Yes. Actually, it is compared to submandibular gland, silolithiasis in parotid is less only, sir. Okay, why? It is more common in that submandibular gland? Because submandibular gland secretions are viscous, and it is anti-gravity secretion also, that be stasis, and the Wharton's duct is hooked by the lingual nerve, so that can lead to obstructions. Yes, very good, very good, very good. Okay. Hmm. Okay, if deep lobe also involved, then what you will do?
Then we can do a total conservative parotidectomy, sir.
Okay, what do you mean by total conservative parotidectomy?
Both superficial and deep lobe is removed, but the facial nerve is not removed, sir.
Okay.
Static.
Okay. If accidentally if you injured that facial nerve, then what you will do?
If it is clean incision, then we can again suture it, sir. If there is a segment is lost, then we can do a grafting, sir,
Okay.
with great auricular nerve or a sural nerve graft.
Okay. Very good. Okay. Anyway, you want to do total conservative parotidectomy, even some malignant conditions. Okay.
Mm.
Okay. When what are all the uh, timings you will do resection of the patient?
So
When
if
you will
there is
of the patient? Yes.
pre-operatively itself, there is any facial weakness, mostly they'll remove the facial nerve, sir.
Yes. Very good.
Uh, and if there is a perineural spread,
Okay.
or otherwise there is infiltration of the nerve, sir, by malignancy.
Okay. So, well, in the intraoperatively, if you are seeing that the tumor is infiltrated to the nerve, then you can remove the facial nerve. Okay, and you are sending for frozen biopsy, and if the margin is negative, positive, then if the sometimes with the naked eyes you can't see that the involvement of the facial nerve. Okay.
Okay.
So in the facial nerve side, if the margin is showing positive, you have to remove the facial nerve also. Okay.
Okay, sir.
Okay. Mm. So you are telling this is a benign condition.
Yes, sir.
Okay. So slow growing time, slow growing growth, everything. Okay. So when you will tell this is a malignant condition?
So history, if there is any sudden swelling, sudden increase in the size of the swelling, or sudden pain in the swelling, in the
Okay. Actually, sudden increase in size, not pain. Okay.
oh,
Okay. Okay.
then on a examination, there is some skin involvement like ulceration or erythema, something. Skin involvement is there.
Okay. Very
Or
good.
there is a lymph node involvement.
Okay.
Or there is a facial nerve involvement, sir.
Okay.
Or there is a restriction of jaw movements.
Okay. What, pardon?
Restriction of the jaw movements, so the jaw.
Okay. 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 And also the tumor becomes hard. The tumor consistency will be hard, and also causes skin ulceration, and also deep muscle involvement. Okay. Fixity to the deep muscle also. Okay. That also will give clue for deep lobe involvement. Okay.
Okay, sir.
Okay, can you tell me how will you, well, doing the another important question I forgot to ask is how will you identify patient?
During an operative, sir.
Yes.
Using 4 pointers, sir.
Okay.
First is the Conley's pointer or the tragal pointer.
Okay.
The nerve is 1 centimeter below and deep to that pointer. Next is the upper border of digastric.
Okay.
Then posterior belly of digastric. Then over the styloid process.
Okay.
And last is squamotympanic fissure, sir.
Okay. Okay. So another thing is between the one more point is that to find out that patient. Okay. Anyway, when you will find that this is called the antegrade technique to finding out the patient.
Yes, and retrograde is also.
Yeah, one more technique, retrograde. Okay.
Hello, sir.
Yeah, tell me, when you will do that retrograde technique to find out the patient?
When there is a recurrent tumor or recurrent, if there is already surgery done, then we can do a retrograde.
Yes, okay, very good. So if the patient had already surgery, it is very difficult to find out in the antegrade method. Okay, then we can find out from the retrograde technique of finding the trunks. Okay. Okay, how many trunks is present in the facial?
First, it divides into two trunks, sir. Cervicofacial and temporofacial trunk.
Okay.
Temporofacial will again divide into temporal and zygomatic branch. Then cervicofacial divide into upper buccal, lower buccal, marginal mandibular, and cervical branch.
Okay. So you told that the facial nerve after we cut the facial nerve accidentally. What are the graft we can use?
Mostly we can use a great auricular nerve, sir.
Okay.
Then we can use sural nerve.
Okay.
Or ansa cervicalis. That one can use.
Okay. 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 Very good. So I think almost we covered all the things about. Oh, 1 minute. Oh. Okay. So, what is called a radical parotidectomy?
In radical parotomy, the parotid, both superficial deep lobe, facial nerve, and the lymph node is also removed.
Okay. So I think we have covered almost all the topics of parotid. Huh?
Yes.
Okay. Benign thing, classification, viral parotiditis, complication, bacterial parotiditis, alcoholism, smoking, and superficial parotidectomy, nerve preservation, total parotidectomy, total conservative parotidectomy, radical parotidectomy, surgery after parotid surgery, complications, Frey's syndrome, anatomical location, and also Karthikeyan sign. So we almost discussed all the points. Okay. You actually, what's your name, doctor?
Rizwana, sir.
Riswana. So Riswana presented very well, and also she answered very well. I congratulate her.
Thank you,
And,
sir.
because of your answering only that we have finished this session within 1 hour. I planned to take 1.5 hours, but you almost answered all the questions. So you didn't give me any work to write or teach. And thank you very much.
Thank you, sir. Thank you.
Sorry, I think it is useful to you. And I want you people to present long cases more, because that's the thing we can discuss 2 hours like that. Okay. And also you have to tell before 1 or 5 days.